Hi, my name is Marie Romagnano, founder of Healthcare Professionals for Divine Mercy. I'm so happy to present to you our educational conferences that integrate medicine, bioethics, and the spirituality of divine mercy in patient care for healthcare professionals. Because of their importance, even if you're not a medical professional, we invite you to join us. Today, I wish to offer a summary of Dr. Scott Bateman's presentation called Critical Thinking About Faith in the Intensive Care Unit. In this talk, Dr. Scott Bateman, who is the Division Chief of Pediatric Critical Care at the University of Massachusetts Memorial Center, discusses the role of faith in the Pediatric Intensive Care Unit. He recalls several early medical experiences he had regarding death, including the first time he did CPR on a dying patient. The patient did not survive, and the ribs got cracked during CPR. Another time, a dying 11-year-old girl asked him, "What is it going to feel like when I die?" He recalls the first time a family asked him to pray with them for their child, and his memories of the experiences as families set up shrines in their children's rooms. He reflected on why he entered this field of medicine and cited the quote from Ted Kuhn, "Years ago, I was challenged to ask God to break my heart with the things that break his heart." And St. Faustina saw Jesus cry when she asked for prayer for her country and especially on the innocent children who were suffering. Jesus said to her, "You see, my daughter, what great compassion I have for them. Know that it is they who hold up the world." Diary 286. Parents come in with a variety and myriad of emotions, reactions, including disbelief, anger, fear, hysteria, catatonia, distrust, denial, depression, and yet all are seeking truth and hope. In a recent survey, parents describe prayer, their faith, and access to clergy as important and most helpful in their journey in this difficult time. Over 80% believed that prayer increased their child's chance of recovery, 79% believed in miracles, and 72% said they believed that God can heal when there is no hope. Over 2/3 welcomed questions when the healthcare provider inquired about their religious beliefs, but only 15% were actually asked. So faith issues are important to the family, but the medical community generally does not bring up the topic. Parents also stated that in addition to recognizing the importance of faith, they desire honest and complete information, access to staff, and emotional support. In another survey, those patients and families who had their spiritual needs met in an ICU setting described a better overall experience. We must remember that patients and families come in with many faiths or none at all, and the healthcare provider must meet them where they are. The unconditional agape love of parents in these difficult situations is so beautiful yet heartbreaking, and the Pietà, the mother of Jesus holding her own crucified son, comes to mind. The first major hospital built in 370 AD by St. Basil the Great was based on the biblical principle of caring for the poor and healing the sick. It appears that we are slowly getting back to these principles and recognizing the role of spirituality in the care plan for the patient and family. We must see Christ in our patients and in their sufferings. I invite you to listen to the full presentation and hear Dr. Scott Bateman as he discusses critical thinking about faith in the intensive care unit. It is truly valuable and memorable. Thank you.
After Brian's talk, I'm going to keep my positive mental attitude throughout all this. And I'm also following that theologic tour de force with Dr. Serpin. I was just trying to keep up. I was trying to hold on as everything that was said was so profound. So I guess I just want to say thank you, Jesus, after listening to that talk. So my talk today is called Critical Thinking About Faith in the Pediatric Intensive Care Unit. And This is a talk that I actually gave at medical grand rounds at UMass Medical Center last year. I've altered it a little bit, but it was actually much harder to give that talk than it is to give this talk, because I actually felt it was one of the first kind of true public expressions within the medical center of how important faith was to what my take on the issues of faith in the pediatric intensive care unit. And I felt like I was in uncharted territory a little bit, but it actually went very well. I was very pleased. Can't hear me? Apologize. Is that better? Okay. All right. And I've actually since gotten a lot of people come to me and have been able to express how important this is to them. And so I've actually started a little groundswell within the medical center of kind of a faith-based approach to medicine. So I'm grateful for actually the opportunity to give this talk here. I'm also grateful that there's a couple folks that I recognize out there, a couple of nurses from our pediatric department. I'm very grateful for their presence. I have actually one nurse from the pediatric intensive care unit who's also here, Kathy, so thank you for being here. And with that, I will move forward. I do have no financial conflicts of interest. I do like to disclose that I was a convert to Catholicism in 2004. That's been a topic of previous talks. It will not be discussed that much today. I have the picture of the Sacred Heart up there. It was actually at the Sacred Heart Church down in Atlanta, Georgia, where I had my own conversion experience. So I hold that image to be very dear to me. My objectives of the talk today are to try to express and share with you some of the prevalence of parental spirituality and its expression in critical care. Try to actually bring some science into it. There's actually been a emergence of science into the study of faith in our medical field, and to outline a unique program that I was lucky enough to be a part of, clinical pastoral education for healthcare providers, and then also just in general promote an awareness of the influence of faith during family crisis. I tend to use family crisis instead of patient crisis in pediatrics. They're interlinked. So this is Lake Tahoe. This is where I grew up. I actually grew up right on that peninsula that's sticking out into the water. And yeah, it's a beautiful place. And anybody who's actually had a powder ski day in Tahoe knows that that's where you actually feel that God is present, because your heart is bursting with joy, and you hear just hoots and hollers as you're going down the slope. And it's my first experience with the divine. And it was really that bursting with joy experience. I'm now in a different field, different place, the same sense of divine, but for different reasons. My heart is breaking for these children, and the poignancy of this scene it's impossible not to open your heart up to a sense of the divine. As I kind of explore back and think about how I end up being here today talking to you about faith in the ICU, I think of some of my early experiences leading up to this, and I think of my first time doing CPR, which was when I was a fourth-year medical student, and having the experience of being in the room alone with a patient who had a esophageal hemorrhage from liver disease, having to actually initiate CPR, having him not make it, having him actually having his ribs break during the first time he pushed on his chest because he was so brittle. And that whole experience was incredibly difficult to manage as a med student, and everybody's first death experience has a profound impact on them. And I think that really did fuel a lot of kind of speculation about things. I had an 11-year-old girl when I was a second-year resident who honestly and earnestly asked me, what's it going to feel like when I die? She had lymphoma. She was going to die in the next couple of weeks. She knew it. And being able to try to counsel this little girl in a way that was loving, and as a physician, as a spiritual guy, what was my role there? And I think that also was an example where I needed to kind of understand my faith better to be a better doctor. I've had many families actually ask to pray with them, during their family crisis, and in the awareness and presence of faith in crisis situations becomes much more apparent as you kind of look for it and you're aware of it. Seeing shrines set up in rooms that, as the suffering is happening, there's just in this very clear demonstration of their faith. And I think the more I kind of saw that, the more I was able to kind of recognize that this was very critical to their experience. So then I say, well, why do this? Why am I doing this field of pediatric critical care? I like this quote a lot because it actually sums up a little bit. It's kind of that calling to do. I always say I've tried to talk myself out of doing pediatric critical care many times, but somehow there's a call to continue to come to the bedside. And I feel like I was challenged to ask God to break my heart with the things that break his heart, and just an awareness that he is crying as well for these kids who are sick, the one crying for the families who are struggling through this. And St. Faustina actually demonstrated this nicely when she described the experience of Jesus actually getting tears in his eyes when he sees children who are suffering, and the compassion that he has for them. Know that it is they who uphold the world, and being able to kind of appreciate that, knowing that God's crying with you in the setting of these critical illness was actually became a very powerful message for me. And I also started to see some of the other aspects of being in the midst of this human weakness, human suffering. John Paul actually said it nicely when he said, the springs of divine power gush forth precisely in the midst of human weakness. And I like that, being able to kind of appreciate that there's actually something beautiful happening at the same time of this divine power, this divine love that you see. And I actually like the word gush in this. And I actually, St. Faustina uses the word gush also when she's describing the image of the divine mercy in front of it. Just the light just gushing forth, and the power of families and children in the setting of these crises was just, once you're able to open to it, actually was literally gushing, just nonstop, and particularly the love between a family and their child. So we have lots of examples of forms of suffering within the ICU. Clearly, the patient is suffering, and in our situation in the ICU anyway, we have morphine and Versed and benzodiazepines to help a lot with their suffering, and a lot more apparent sometimes is the family distress, but also awareness that there's healthcare provider distress too, and trying to keep all of those things in mind. So I like to just kind of give a little background about the pediatric deaths, and so that I will say before I say that most of our patients get better. About 98% of our patients who come to our pediatric ICU walk out of there, and it's a very uplifting place for the most part. But pediatric deaths is a reality, something we do deal with in our unit on a fairly regular basis, and each one is a big deal, and each one is worth at least pausing and trying to do the best we can. There's approximately 55,000 deaths of children a year, most of them in the first year of life. And in the first year of life, it's mostly from congenital diseases or from prematurity. But after that, beyond infancies, these are the ones that we deal with in the PICU, mostly unintentional injuries, some congenital anomalies, cancers, And unfortunately, even intentional injuries occasionally is something we have to process. You still can't hear me in the back. Maybe I'll hold it. I apologize again. I'm keeping my positive mental attitude. Okay. And the reality is that pediatric end-of-life care actually is occurring within our acute care hospitals. So we have patients right next to each other that are surviving, others that are dying. And so it's a continuum that we have to deal with. In fact, 2/3 of the deaths in the ICU actually follow withdrawal of support. So there's an active decision to allow someone to die. So our approach towards the death of a child becomes very much part of our experience in the ICU. And what I've learned is that what happens at the end of life really, really, really matters. And how much, even though this child is being supported maximally, you can still see that there's a little stuffed animal at the bedside. There's an awareness of the humanity of this child. I also had an experience where I was walking through the lobby of the hospital. I had parents come up to me who I couldn't recognize. Somehow I recognized them a little bit, but I couldn't place them. And they said, "Thank you so much for everything you did for our child. And we remember every single piece of the time we were with you." And I subsequently found out that the child had come in florid septic shock and had died within 3 hours of admission to the ICU. And I remember walking out of that room feeling like a failure, not being able to recognize that the experience that the family had was so seared into their brain, and being able to kind of be an awareness of what their experience was like and what they are listening to, and how every single word we say during that time actually matters to them. And people will say, how do you go into pediatrics? Because you have to deal with the parents. And the parental response can be anything on this list. And I think that the overwhelming emotional outburst that can happen during a child's illness is something that is undeniably difficult, but is also, I feel deep down, is based on their seeking for hope and looking for trust. And if we can kind of keep that in mind, it actually really does make a major difference in our ability to kind of interact with families. And they really do, those emotions are coming from the right place. A survey of families who've had to deal with end-of-life issues for their children, what are the things that they really found to be the most important? They found that prayer, faith, access to and care from the clergy, and belief in the transcendent quality of the parent-child relationship, all those were at the top of the list of things that they felt that they needed. And what is it that they held on to during these times? And the values that they wanted most of all were hope, trust, and love. And I think that gets back to the universality of everyone. So I just wanted to kind of, part of this is to kind of put a scope onto what exactly is the faith that we're experiencing, and how little we've incorporated into our medical kind of thinking, is how important faith is to people out there. And not just to this room, but all across every patient who comes in, that almost 80% believe in God, and an additional 15% believe in a higher power, universal spirit. So that's a vast majority. 84% think praying for the sick improves their chance of recovery. So they're all going to be praying. 84% of the patients are doing some form of prayer during their time in the hospital. 79% believe in miracles. 72% believe that God can cure people with no chance of survival. So that hope for a miracle is real and is something that is very pervasive. This is a title of an article from MSNBC, really kind of, I think, crystallizing that sometimes faith is actually at odds with medicine. This is God versus the doctor, saying that we actually believe that God's stronger than whatever medicine you have. So we should, it just creates a conflict that I think that we need to try to do an end around and come back and join hands with them on this. Religious beliefs and practices. This is actually a survey done to compare the general public versus physicians and what is that their faith understandings are. Looking at religion as a guide to life is 75% of the general public, 69% of physicians. Importance of prayer in everyday life. You can see is a higher percentage on both. I pray for individuals or patients is 76% of the public, 54% of physicians. And medical practice should be informed by religious principles is actually not as high, but I think it's interesting. That's only one of the physicians are a little bit higher, so there's a little, maybe we are pushing the envelope a little bit there. But overall, I think just trying to reemphasize how important faith is to everyone who walks into the door to either our ICU or to your clinic or to wherever it is that you're practicing medicine. Even miracles. What is the kind of sense that miracles happen? Miracles are expected to have happened in the past by 86% of people. That's 85% believe that a miracle could happen now, and that medical miracle cures are actually true, and 45% believe that. And this is something we see a lot in the ICU, that this constant belief in a miracle, and that we can keep praying for a total cure. One of the things that I actually like is an article published in 2009, a practical approach to families who expect a miracle. And these are some points that I think that I do try to hold on to, and I think can help people who are in this situation. One is you need to understand what the miracle is. There are some people who have very fixated on one particular type of miracle that they're looking for, which is complete cure, and be able to kind of understand that, what that means to the family, what kind of cure are they talking about, and make sure that you emphasize non-abandonment, meaning you don't want to lose someone because they're expecting a miracle and a miracle is not going to happen. And then what I really think is one of the more important one is to reframe the meaning and manifestation of a miracle. And I think that the definition of a miracle is extremely broad. And the way to help is to discuss different ways that a miracle may actually happen from the situation. And you may not recognize the miracle till later. And I think that it's hard for them to grasp sometimes, but I've had people come back and say, that really was a miracle, that his high school came together the way they did and created something for this child who passed away and has had a lasting effect. Those type of things they don't recognize at the time. And then the last one I actually like the most, that if a miracle is going to happen, we have no control over it. So, we're just going to keep doing what we do. So we will not be able to prevent it if we decide to withdraw support. The miracle, it's not like preventing a miracle from happening. If the miracle is going to happen, it will. So study looking at whether we should be incorporating spirituality into our discussions. This is in adults. Found that in this survey, 51% said they were very religious, and that 90% believed in prayer, and that almost half said that religious beliefs would strongly influence their decision-making if they were gravely ill. Almost two-thirds thought that they would welcome being asked about it by physicians, but only 15% ever had been asked. 16% said they would not, which is pretty small. But regardless, the number that were actually got a religious or spirituality conversation into their encounter was extremely small, even though there does seem to be a much higher desire for it. When we look at all comers to the pediatric ICU, what do parents really want? These are the top 6 things they want addressed and they want to be able to count on. And as you can see in the top 10 is number 6, which is faith. All the others are obviously incredibly important, but the fact that faith made it such high priority is something we should all be aware of. And then a study looking at intensive care unit patients looked at family members of adult patients who were dying in the ICU and found that there was a very strong association between the spiritual care and their total ICU experience. The better their spiritual care, the more positive they expressed their experience was. And that the spiritual care was particularly enhanced when there's either a pastor or a spiritual advisor involved. In our unit, we have, in our medical center, we have a dearth of chaplains, and it can be quite difficult at times to have this readily available, but we encourage families to engage their own spiritual community, and a lot of times their own pastor, their own spiritual advisors come in, and that's something that we strongly encourage and do our best to try to have them part of the team. And then how is religion affecting care? This is actually a first major journal, I think, to publish an article like this, which was looking at the religious coping, defined as how much they go to church, how often they are praying, how much they consider religion to be a form of support and solace. Found, and I'm just going to highlight the intensive life prolonging care. If you had a positive religious coping, which was high, then you had a higher chance of actually being in the ICU with life prolonging care. And the odds ratio was significant. So this actually created a lot of kind of head scratching and said that people who are better able to cope or had better religious coping actually had more use of healthcare facilities and ICU life prolonging care. So, one of the things that we've thought is that, all these folks, they want to go to heaven, but no one wants to die. So one of the things we interpreted from that. I put this slide just as a recognition that there's all faiths out there and they're all coming in, and our job is to actually meet them where they're coming from and finding a way to interact with all forms of faith that come in. Sometimes it actually dictates our care plan. This is a survey done, kind of a guide to the different religions and how they actually approach some of the hot button topics that we deal with, withholding and withdrawing support. That if you have, if you're a Greek Orthodox, the option of withholding or withdrawing actually isn't accepted among their faith. Organ donation is also organ donation also is not considered part of the Buddhist tradition. And so being able to kind of have some knowledge of how faith is actually going to influence some of their decision making actually is also key to our ability to kind of interact with them. So finding out where they're coming from. These are just generalizations that I don't like to hold on to too much. But regardless of that, one of the things I try to bring back is the universality of, no matter where you're coming from, the universality of finding yourself in a situation like this. When I saw this pietà, I recognized it right away as a vision that we've seen in our ICU, unfortunately, too many times, of a mother holding her child who just passed away. And just seeing how Michelangelo did her face and did the whole image is just incredibly powerful. And recognizing that it doesn't matter where you're coming from, that that expression, that emotion is going to be inherent in all of us. And that universal expression I'm going to try to capture a little bit in some pictures as we move forward. Contrasting this picture with the one prior to it, looking at how the mother's face is so similar, I think it just drives home. This is a little boy with spinal muscular atrophy who is going to die probably within the next couple of hours, and just her holding him, and that just that mother's anguish. Like I said, it doesn't matter where you're coming from, just being able to, it's palpable. Or being able to express themselves in prayer at times of extreme difficulty. This is a child who has a port. He's got neuroblastoma. He's actually already had a bone marrow transplant. And this is the parents actually at the end of his life getting into bed with him, holding his hands and praying with him. And I actually don't even know what faith they are. And it's just that ability to kind of encourage that and allow them to express that is something that we were trying to capture here. We're seeing unconditional love, the type of agape love that is described by Jesus' ability. This is a teenager boy who was in a near drowning accident when he was about 3 or 4 years old, who has a set of parents who are just beaming with the love they have for their child, and being able to see how they can have that sort of unconditional love and express it, and it's able to witness that is something that is beautiful to see. Or being able to have hope for some sort of explanation for this, some sort of, not hope for survival, but hope that is beyond what we can imagine. This is a child who was also had congenital heart disease, about a month old, who was also recently taken off the ventilator, and seeing this family come together and seeing that there's actually even a smile there in the face of this. They were clearly able to hold on to some sort of hope. That is something that you can't describe. This child is doing well. Not all of them. Pictures here of patients who have passed. This is a little baby who was born 26 weeks, supposed to be 40 weeks, premature, who has a tracheostomy. This is the trach right there. So he's getting oxygen through the trach tube. And the trials and tribulations that this child has been through over the first year of his life have really tested the faith, tested the love of this family, and has allowed, but has given her a chance to really express her love for this child. And this child is actually thriving now. It's really nice to see. And the children themselves give us some very basic theologic concepts. I know that I let the pictures speak for themselves. This is a little girl who's on ECMO, which is oxygenated blood is going in this tube, and venous blood is coming out this tube, and she's on total heart-lung bypass and is on a ventilator, and she is essentially being supported by an external heart and external lung. And to see her essentially have loss of all basic bodily function and then recover, come off ECMO, and do extremely well is just an incredible vision of rebirth. This girl actually had a horrendous lung infection that slowly got better, And when she was extubated or taken off the ventilator at the end of this run, which was about a month and a half, her first words were, "Hi, Mom." And the entire unit actually broke down in tears just to kind of see that kind of rebirth. And Mom was on the floor because she couldn't control herself from her crying. It was really remarkable. But also resilience. This young lady was in a first time skiing in Wachusett. She fell and fell into the woods, hit her head into a tree. She was in a coma for about 3 weeks. This picture was taken the day she opened her eyes for the first time. She eventually went to rehab, and she is currently finished in last year, graduating from college. And so her ability to kind of come back, and the spirit of this child, and most of our children have this desire to do well. They want to get better. She was a perfect example of that. She didn't want to be there. She said, I'm out of here. I want to get better. And seeing that resilience was very powerful. Dying with dignity is this is another kid with spinal muscular atrophy, which is a form of neuromuscular disease where you have loss of all motor function except for your brain power, and the ability to survive off of mechanical ventilation as they get a little bit older becomes more and more impossible. So this picture was taken the day before we withdrew support, and this was part of a party that the family had put together for the child. It was almost like a mini birthday party. It was actually her 6-month party, where they decided to have a birthday party for her instead. And then I put this up here because I know it's hard to look at, and I apologize. All these pictures are hard, but they all, I think that this is an example of what I'm hoping to express is the innocence of this young boy, what he's going through for some unknown reason, and being able to kind of understand that and put it into context. I try to help us to see it in a different way, to see the connection that this child has to other picture that we know that a lot of people also have a hard time looking at. I know a lot of non-Catholics who say, I can't look at that crucifix because it's too hard, it's too difficult for me to see. Being able to kind of view it and understand and still be outraged, still be sad, still be devastated by this, but be able to kind of step back a little bit and say, okay, maybe what we're doing is for a reason. There's some sort of explanation we won't understand, we'll probably never understand. But being able to see Christ in our patients, I'm hoping is something I try to encourage, because this is the true, for me, kids suffering in the ICU is the ultimate innocent suffering, and be able to see that is very powerful. So this is a schema that I found in a Journal of Palliative Medicine, which is hard to look at, and I hope you probably can't see it too well on the back, but on the outside here are a lot of different forms of expression that we see within the medical field, whether that's their prayer or their Bible study, or they're trying to understand about human goodness, whether they are rejecting God, whether they're feeling anger, whether they also have peace. And what this is showing is that at the core of all of those outlets is actually their religion, spirituality, or life philosophy. And we only get to see these, but the more you can kind of delve into kind of the sources of them, the more you can kind of get to the core of what it is that's it's kind of forming those expressions. So I'm going to shift gears a little bit to the healthcare worker, because I mentioned that is something that also there's distress going on. It's hard to witness other people suffering, and it's important for us to kind of be able to minister to our patients as well as possible. So this next part is kind of understanding the faith of the physician and how to encourage it, or the nurse, or any healthcare provider. So what is the kind of breakdown of faith among physicians? And you can see that 80% of U.S. patients describe themselves Protestant or Catholic. Only 60% of physicians. You're 26 times more likely to have a Hindu doctor than the general population, 7 times more likely to be Jewish, 6 times more likely to be Buddhist, 5 times more likely to be Muslim. And so there's a wide variety of faith traditions, and obviously some are overrepresented. And there's family practice and pediatric MDs, actually, I'm glad to say, were far more likely to carry their religious beliefs into all of my other dealings and to look for God for support and guidance. And psychiatrists and radiologists were least likely. I hope there's none of them in the audience here. But And looking at pediatrics in general, I like to kind of give ourselves a little kudos that we do actually have a high degree of belief that spiritual and religious concerns are relevant to practice. But despite that, we still have more than half who never really talk about it, and very fewer even than that do it routinely. I think we tend to think of pediatricians taking care of well children where it's not as relevant or harder to engage. But once they actually enter the hospital or have some sort of illness, I think this hopefully is going up much higher than that. So not only is there different religions but there's among the care providers, but it actually influences how they practice too. And this is a European study looking at if you were Jewish, Greek, or Muslim, that you were much more likely to withhold care than to withdraw care. And if you're Catholic or Protestant, then withdrawing actually occurred more often in physicians. So it's clearly affecting what we're presenting to patients. This reminds me of my father-in-law, who always has said that if he always wanted a Jewish doctor because they don't believe in the afterlife, so he thinks he's going to work harder for him. So, so we're left with we still have a lot of questions that are unanswerable. Are we trained to address how to address a patient's spirituality? Not really. Are we able to cope with unanswerable questions? This was that little 11-year-old girl who asked me what it was going to be like to die. No one taught me that in medical school. There was no way I could answer that question without really kind of delving into my own heart and being able to kind of hopefully give her some sort of answer that made some sense to her. An awareness that every patient and family situation is different, and that an awareness that the technological advances, particularly in critical care medicine, have entrenched our role in life and death decisions. We are actually having to decide whether to take the ventilator off or to not do the ventilator much more frequently now than we had in the past. Are we doing too much or are we doing too little? I have a slide for that in a second. And how does our own spirituality affect our patient care? These are questions people should be asking themselves. This is kind of the mantra for medical school, is no matter what, we're just going to fight on. And I think that is an approach that is kind of the linear scientific model. I think the more we can kind of appreciate some of the gray area of medicine, some of the art of medicine, we can actually pull back on that a little bit and say, are we doing the right thing? So I mentioned about doing too much. Because of our technological advancements, have we put ourselves in a position that we may be kind of putting patients through procedures, technology that may not only be not necessarily prolonging their life, but maybe actually causing more harm? And there was a high percentage of people in doctors, nurses, other subspecialty MDs who actually felt that at times they have been providing care beyond what they feel comfortable with, and that being able to kind of express that to families, being able to appreciate how you can talk about that is also part of the spiritual realm. And this, another article from JAMA that was intended to give some basis for doing your own spiritual search. These questions are coming up frequently. Why me? Why my child? And how we process them and how we counsel patients actually has a major impact. And our ability to have answers to intangible, unanswerable questions or qualities and formulating a response, it may require a shift to this spiritual domain. And exploring this domain requires transcending an individual's physical, cognitive, and emotional sense of reality and individual's material, tangible world. This is actually groundbreaking to be in JAMA, which is Journal of Medical of the American Medical Association, to have an awareness and an exposing of this aspect of medicine, which is relatively new to the medical literature, and it's refreshing to see that it's finally making some headway. And then just another way to put it is that to heal a person, one must first be a person. So our ability to kind of recognize our own self, that we must understand not only what disease and injury do to their patient's body, but what disease and injury do to them as embodied spiritual persons. Grappling with, again, those transcendental, unanswerable questions. So our ability to kind of meet people there is what we're trying to foster. And Thomas Merton, actually, I like this quote because I think it's the irony of it is quite telling to me, that we must try to accept the suffering of others and try to make it holy, appreciating the divinity of this suffering in some way or form, but that it is by far the hardest thing because nothing so easily becomes unholy as suffering. And being able to recognize both things are true is things that we need to try to hold on to. When we look at publications looking at key wellness strategies for physicians or healthcare providers, we find that second on the list here is religious belief and spiritual practice, so that we can actually address some of the things that actually Dr. Thatcher was talking about, ways that we kind of regenerate ourselves. And the more we can kind of focus on these, the more we can actually be present to our families. For me, it actually, I had my eyes opened when I saw this publication in Critical Care Medicine in 2005, and it was an intensivist, which is what I am, in a spiritual care training program adapted for clinicians. I was like, that's kind of interesting, and found afterwards that it was put on by the Schwartz Center in collaboration with Mass General. The Schwartz Center is a nonprofit organization in Boston that focuses on dedicated to strengthening the relationship between patients and caregivers. And it is their ability to kind of foster spiritual growth of physicians is something they actually put together into a fellowship, which I was lucky enough to get. And was able to enroll in this thing called the Clinical Pastoral Education for healthcare providers at Mass General Hospital. And it was, this is not meant to be an advertisement for that program, but I do like to encourage people to consider it because it was very, very powerful. I'm just going to summarize it a little bit. This was a 5-month program that was in the chaplaincy department. We had 6 providers in our group, 4 doctors, a nurse, a social worker, and a chaplain supervisor. We had all-day meetings on Mondays, where we had weekly reading assignments, process notes, and we had to lead 2 interfaith prayer services. What were the skills that they were trying to teach through this? Evolving from active listening to being present. And I think that is one of the key aspects of being able to meet people where they're coming from, to change the focus of content into process. Like I said, meeting people at their level, being able to engage in a spiritual dialogue. And I think by far and away, this aspect of it was one I hadn't been able to do, to actually talk to people about their faith, to talk to them about their what they're yearning for, what's the source of their hope, and understand these relationship dynamics. And that schema I put up about how at the base of everything is their life philosophy, understanding how that's influencing their decisions is something that I had a new awareness of. We had didactics on all these topics that anybody who's interested or who does healthcare would know that all of these are relevant on some level, and being able to kind of at least spend some time talking about them, and is so needed to augment our whatever medical training we've had. We had writing assignments, writing about God, writing about suffering, writing about covenants with God, hope, and our call, or why did we go into medicine, why did we go into nursing in the first place. I think anytime you can kind of recharge yourself and say, why did I go into this in the first place, I think is incredibly valuable for anyone who does this on a regular basis. And being able to write down some of the spiritual conversations that you don't even realize you're having on a regular basis. And I'm going to go through a couple of them in a minute. Being able to discuss the process notes, which is basically a journal entry at the end of each week, which outlined all the discussions, all the kind of things we felt were touched by God throughout the week. I mean, you guys in the priesthood know you do this all the time, but we don't learn this in medicine. So this is something that was new to me, and something that I found to be incredibly powerful. The small process group was actually not only was there a writing part of it, but it was actually coming together, sharing with our group, and being able to hear each other's struggles, hear each other's faith-based discussions, all their losses that they felt, their pride, their joy of experiencing someone getting better or getting out of the hospital. And that was something you don't get to do it reminds me of college, when you're late night having pizza with your buddies. That's the last time you really had this chance to really have nothing else going on. You're just here talking about your struggles in life. This is a verbatim from one of the discussions I had with a mother. Yesterday I was having a really bad day, and I was close to tears on multiple occasions. The nurse was so kind. She offered me blankets, food, drinks, and everything that I didn't need. I wasn't hungry, I wasn't cold, I wasn't tired. It was my heart that was hurting and feeling empty. If she had just offered me a prayer, I think it would have been just what I needed. And I think that it was this was completely unsolicited. I just was asking her how she was doing, and this came out. Or a family member who says, hope was not coming from any of you, but none of you said anything to dash our dreams of a miracle. And I think being able to kind of give bad news without diminishing all hope is also an aspect of medicine that we don't necessarily learn in med school, but is something that I found to be a very powerful anchor for people to hold on to, even if it's a miracle. Here's what a PICU nurse said when asking her, is faith important to you? I've seen too many unbelievable things in this unit not to believe that there is a spiritual aspect of this job. There are so many times, even when there isn't a good outcome, that you can feel God in the room. And you know how much our nurses are invested in their work. You know that in order to do this work, we have to be able to have faith in something. And I've never wanted to impose my own faith, but I follow the lead of the family. And one of the things that I found through this course in interviewing some nurses is how much I was unaware that the nurse at the bedside, the constant interaction with the family, was more spiritually based than I even was aware of. And I think that kudos to the nurses out there for how much they've kind of advanced the field of spirituality at the bedside more than others. And I think Marie's whole mission here is to help encourage anyone involved, but I think the nurses have been at the forefront. Patient family, I'm trying to write to him in this journal. It's my way of trying to do something, and that and a lot of prayer. Just a little question, have you been praying? Are you kidding? This is all we do. This is all we can do. We just want him to live. We are asking God for him to come back to us no matter what. And it wasn't that little question, have you been praying? I wouldn't have known that answer. That's not something that comes up in normal conversations. Just opening yourself to an awareness that that's maybe what's going on, and you can just like scratch the surface, and all of a sudden this kind of comes pouring out. And even a med student actually gave me a story once where she said, I saw a Bible on the side of the bed and asked her if she had been reading it. When she said she could not read without her glasses, I offered to read it for her. And it was interesting to hear from the medical student's perspective, because she actually bonded with that patient in a way that she never had prior to that experience. And she has used that to kind of fuel her own spiritual investigation into families throughout the rest of her career. So it's been really nice. This was a clergyman who came was a minister to a particular family with a really bad car accident. I was hoping, as was the family, for a miracle. I remember being amazed that you welcomed my request to pray for the young girl and for the family and for the hospital staff. And when the parents agreed to move forward with organ donation, I was absolutely stunned. That, in my mind, was a miracle. And this is one of those examples I said about the miracle may actually be not something you recognize right away. This young girl actually gave organs to 7 different people. And it was truly remarkable how many lives were touched by this tragedy. And the family has gotten so much solace out of knowing what their daughter's been able to do. Even the residents, a big part of our job is teaching residents, having them appreciate that they're learning to do critical care, being able to kind of allow them to express some of these things. That I was just an overwhelming sense of suffering and feel for these kids, particularly since I had my own daughter. I just wanted to give her a touch to say I was sorry. This was a resident who had, during a code situation, did one of the most touching things I've ever seen. They were doing CPR to this girl, and she took her hand and she wiped the hair away from her eyes in just this very touching way in the midst of this code. And everyone in the room kind of noticed it, and it was until afterwards she broke down and said, I just felt like I needed to do something to touch her, to say I was sorry. And it was just incredibly beautiful. And that same resident actually said, can you say a prayer for us on rounds, after she was able to express this. And being able to kind of allow that to be and allow that to kind of become a part of our culture is something I'm trying to open ourselves up to.